um, to understand, okay, how effective our cancer therapy is going to be. So these are actually the precise principles, okay, of using cancer therapy. So we know silver bullet isn't out there. Silver bullet is again like, okay, this is the cure for all, or this is the exact targeted treatment. Conventional chemotherapy targets have been the cell cycle, microtubules, and DNA. This is all conventional mechanism that we discussed in the previous classes. And combination chemotherapy improves the response over single agent, but dose intensity must be maintained. So we give combination therapy more than one anti-cancer to ensure, as you saw in one regimen shop I was telling, we use many drugs to ensure, okay, it acts on several steps in the mechanism and ensures that the cancer cell gets killed. Okay, it's like it's like resistance, as you saw in the antibiotic. When I was teaching antibiotic, we use sometimes multiple antibiotics to ensure that the bacteria gets killed rather than getting back again after some time. So to ensure that we use combination therapy even in cancer. So it is better to treat metastatic, micrometastatic disease. Phase 1 trial defined as MTD, which is a maximum tolerated dose. This may not equate maximum therapeutic dose. I hope you remember what is maximum tolerated dose. So maximum tolerated dose is something like toxic dose, what the patient can tolerate actually. And maximum therapeutic dose is the maximum therapeutic, the highest dose that is therapeutic in nature. So if you go before that, um, beyond that, the patient may experience the side effect, or the higher dose may not have any therapeutic effect. So what is being told here is this MTD, maximum tolerated dose, and maximum therapeutic dose may not be. You cannot tell, okay, if I have reached the maximum tolerated dose, that's the maximum therapeutic dose, or if you have given a maximum therapeutic dose, that's the maximum tolerated dose. So sometimes even after giving maximum therapeutic dose, if it is not reached to maximum tolerated dose, depending on the patient response, you may most likely take decision to increase the dose, or sometimes even if the maximum tolerated dose is reached, then you have to figure out, okay, by what extent you already exceeded the maximum therapeutic dose. For classical chemotherapy to be effective, cell proliferation is required. Okay, so if the cell is not proliferating very nicely, as we saw, highly sensitive cancers, low sensitive cancer to chemotherapy. Why they are low sensitive? Because the cells are not proliferating very effectively. Okay, very faster rate. So the cancer, anti-cancer drug acts on those rapidly proliferating cells. But if the cells are not proliferating that rapidly, how this anti-cancer is going to be effective? So such cells, such cancer we call as indolent. Okay, they are very slowly growing cancer and are typically very resistant. Okay, so I gave you the example, which are the list of cancer which are not very effective to the chemotherapy. So these tumors become indolent, and they determine the survival. Almost all who die with cancer have been treated with chemotherapy. So the drug resistance is a major cause of death actually. So many patients who die, who are suffering from cancer and die in the end stage, like after shifting to the palliative and all, where physician, where the healthcare professional doesn't have much option to manage and much drugs. So there is high chances that they die because of the drug resistance. That there are we overran of the drug that we have to treat them. So drug resistance can stem from hosts, tumors, and even the cellular factor. This is something important that you should understand actually. This is, I have one more picture. Okay, it's coming up. This is called Gumperzian growth. Okay, this is how the tumor grow actually. This is the pattern, biological growth of the tumor. Okay, this is how it is shown here nicely. One more curve is coming up. See how it is growing. This is the x-axis is the weeks days, and y-axis is the cell number. in what extent it is growing. So growth rate are very exponential in the early stage of the development, okay, and it slow down in the latter stage as the time passes. So initial tumor growth is the first order. So what we saw in the beginning part of the graph is the first order. Okay, it depends. And the growth is very quicker. You see the graph is little steeper than slant. So and the latter become much slower. Smaller tumors grow slowly, but large percent of cell divides there. So smaller tumor, which are small tumor, they grow slowly, but there is very large percent of large percent. We'll again discuss what is this fraction. Okay, what is this fraction of growth? Growth fraction is coming up. So median, this is percentage of cell dividing. Okay, so medium-sized tumor grow more quickly, but with smaller growth fraction. Okay. So similarly, large tumor has a small growth rate and growth fraction. So this is what I was talking. See how nicely it is given in this picture. Um, you have again time in the x-axis and log number of cells in the y-axis, how the cells is dividing. You see clinically detectable tumor, till what number of cells you can detect the tumor clinically. Okay, if it is below that, you may not. Then diagnosis possible. First symptoms occurs in this region when the cell division reaches this number. And when the cell division reaches this number, disease symptoms become incapacitating. So this is again taken from the Dipro. You can go there with detailed explanation. But here, if you see, as I was telling, the beginning part of the curve is the very fast growing fraction. So the doubling time is very short over here, and this is like log exponential growth. Okay, and um, till here we tend to like one type of chemotherapy is given. Again in this phase another type of chemotherapy. Along with that we also give immunotherapy for the greatest benefit. And bulk tumor growth is there if it goes in this region, in this number of cell region. We go for surgery, radiation, and then multiple course of intensive chemotherapy regimen. And here, somewhere here, where the tumor growth is very extensive into the power 12, where it reaches plateau, the patient even can die. Okay, in this because this causes very um, this is very unexpected and high turnover, which even affects many other um, surrounding tissue. So this has become actually the mool mantra of therapeutics. So whenever you read therapeutics, you have to keep this mind in always. Okay, you cannot apply whatever you read here directly to the um, your word or the daily activities. Whenever you go in word, you always have to keep in mind about this risk benefit. Okay, when you are using something, when you are telling something, when you are giving some advice to the patient or to the doctor, so what it gonna how it gonna be affecting, whether it is how much advantage it have, how much disadvantage it have. Mm, so when you give multiple drugs, as we say in cancer, we tend to use many drugs to ensure that the cancer cells gets filled up completely and it doesn't, and the resistance doesn't happen, right? So, so when you give multiple drug with multiple mechanism to